Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to today's milestone in our journey of 52 weeks of Diabetes Essentials, Dr. Sanjay Kalra sir. These online modules are an educational initiative from NRZAL Zero and in memory of Dr. K.K. Agarwal sir. Dear viewers, today Dr. Kalra sir will take us through the second last milestone of our season 1 journey, that is, when to refer, which has always been a dilemma for family physicians. So before I hand over the platform to Dr. Kalra sir to take us through today's module, let me have the opportunity to announce the names of those viewers who have answered the quiz questions correctly in last episode. And the names are Ritu ma'am, can you please share the slides? From Chhattisgarh, Dr. S. Pandey and Dr. Sri Prakash Pandey. From Haryana, Dr. Kamal Modi. From Jammu and Kashmir, Dr. Shahid Hussain Sofi. From Karnataka, we have Dr. K.M. Prasanna Kumar, Dr. Ravi Bhatt. From Maharashtra, we have Dr. Harsh Shah, Dr. Pradeep Pathade, Dr. Seema Shah, Dr. Sriram Naik. From Uttar Pradesh, we have Dr. Sanjay Mehrotra, Dr. Ashley George, Dr. Ashwini Kumar. And from West Bengal, we have Dr. Santanu Kumar Bhattacharya. Dear viewers, it has always been our endeavor at FDC to continuously support our doctors on medical knowledge updation front. And keeping this in mind, we are starting Hydration in Diabetes series from this month, 18th February onwards. Dear viewers, this Hydration Diabetes series is a fortnightly program starting from 18th Feb and and it will go till 13th May in the coming quarter. And on this, Dr. Kalra will be our host, and there will be 7 topics where Dr. Kalra will be accompanied by one panelist from different part of the country. On this 18th Feb, that is on Friday, this program will be live from 9 p.m. to 9:30 p.m. And the first topic will be our body, the water within. And for that, we have Dr. Sunil Kumar Kota, consultant endocrinologist of Diabetes and Endocrine Clinic, Behrampur, Odisha. Dear viewers, you will be able to view these live sessions on the same platform on currently which are viewing the season 1. Any of your colleagues who have missed out or who are keen for updation in diabetes, please share the link with them. And with this, I hand over the platform to Dr. Kalra sir. So over to you.
Thank you, Rahul, and good evening, everybody. Today, we'll talk about a very interesting topic. And this is a topic upon which many of us may have different views. So, feel free to share your comments, your views, your ideas, and let's try to create a system, a framework, a rubric which will allow us to decide when to refer a person with diabetes. Now, all of us who are logged in today are from different parts of the country. Some of us work in primary care, others in secondary and tertiary care. Some of us are general physicians, others specialize in a few fields of medicine. Some of us work in villages, others in small towns like myself, yet others are in tier 2 or 3 cities, and some are in metros. So, in each place, there is a different ecosystem that exists. And that ecosystem actually defines the answer to this question: when to refer. But let's try to create a broad framework for us so that we can understand when we should refer a person with diabetes complications. Now, in most developed countries, the primary care physician is the gatekeeper of the healthcare system. Like in USA or in Canada or UK, for example. In Canada and in UK, as a patient, you can meet with an endocrinologist only after you are referred by a primary care physician. There is no direct access. In India, however, the system is different. Uh, there are multiple gates, multiple gatekeepers, and in the true spirit of Indian democracy, our patient has the choice of meeting one or more than one or none at all physicians. Patient also has a choice of working with modern medicine and alternative or complementary medicine together. So you find a wide spectrum of patient related behaviors related to healthcare seeking. That is one aspect, but after healthcare seeking comes healthcare acceptance. Healthcare acceptance is even more varied in our country. So there are some people who will treat you like God and they will listen to you blindly, they will follow you blindly. There are others who will listen but who will not follow at all. And most people are in the middle. So again, we have a fair idea of these different types of people who come to meet us. It is good, however, irrespective of whether you work in Europe or North America or India, it is good to have an optimal referring process because this referring process will actually make us more effective, more efficient, and it will ensure safety of the patient. Optimal referring is also important because it works as an educational tool for us. Suppose I am an endocrinologist. I have a fair level of competence in endocrinology, but that does not mean that I am equally competent in nephrology or neurology. If I have a good referring process with the fellow nephrologist or neurologist, uh, when he gives me feedback, I can learn from that. And that helps me enhance my educational skills, my knowledge. And gradually, this helps me create a system where I'm able to help the patient better. Consultation with specialists actually helps in improving control, it helps in achieving target, and it ensures that a right process is followed. Family physicians usually refer individuals who have an advanced stage of diabetes because it's very complex to manage their glucose and their comorbidities. But all patients should not be referred. This I will say as an endocrinologist. If all people living in India are to go and show an endocrinologist for diabetes care, we will never be able to control diabetes. We will be able to manage diabetes only if each and every family physician of India is empowered, becomes competent to manage the disease. So, wherever you work in the country, whatever kind of practice you are in, we should be able to manage diabetes. However, some patients should be referred. So, let us talk about those. So, at onset, we say that everyone should be able to s- suspect, screen, and substantiate the diagnosis of diabetes. Suspect, screen, and substantiate the diagnosis of diabetes. But once you have done that, if you have a patient who is clear cut type 1 or clear cut type 2, then go ahead and treat. But if there is an atypical presentation, the WHO uses the term hybrid diabetes. Some features of type 1, others of type 2. There is no harm in sending for a second opinion. If you have a patient who has other atypical presentations, maybe severe symptoms, severe weight loss, you've not seen such a patient before, no harm in taking a second opinion. It is possible that there may be a different type of diabetes, maybe pancreatic diabetes, maybe carcinoma pancreas for all you know. We should not miss that. Patient may have some concomitant disease like thyrotoxicosis. Patient may present with diabetes and thyrotoxicosis together. So again, we would not want to miss that. There might be some other malignancy, some other gastrointestinal disease like celiac disease. So no harm in getting a second opinion at diagnosis. If you diagnose diabetes, do spare the energy to get a urine routine done. And in the urine routine, specifically ask for ketone bodies. If patient has ketonuria, that is urine in ketones, or patient has ketoacidosis, that means urine ketones plus acidosis, a low pH, then again, if you're in primary care, there is no harm in suggesting a second opinion. Try to start insulin unless you have a very clear cut reason for ketonuria. The reason might be having starved last night, having kept a fast, having binged on alcohol the previous night. If those issues are there, you call the patient back after 2 days and repeat the test. Do remember to see whether your lab is doing a good job or not. Urine ketones will usually be reported as trace, small, moderate, or large. Ketoacidosis, if you do not have access to pH, you can just look for the clinical symptoms and signs of acidosis. Tachycardia, tachypnea, low BP, thready pulse. Use of uh, accessory muscles of respiration. So any patient coming with these presentations should be referred for a second follow-up, second opinion. Now, let's say you began therapy, you felt that your patient is typical type 2, but early on in the follow up, in the coming 6 weeks, 12 weeks, 18 weeks, you find that there is an atypical response. Either patient is not responding at all, the symptoms are not improving, symptoms are worsening, weight is not coming back. Patient had lost 20 kg, he came with that chief complaint, still he has not gained even 1 kg. Or now the patient develops ketonuria or ketoacidosis. In all these syndromes where there is a poor response, we should send for a second opinion. If there is hypoglycemia, you had just given maybe metformin 500 BD and glimepiride zero point 0.5 BD, and even then patient develops hypo. Maybe we are missing out on something. What can we be missing out on? Maybe a lifestyle issue, wrong diet, wrong exercise, too much of alcohol. In wrong diet, maybe the wrong meal pattern, meal composition, meal quantity. But if you figured all this out, still patient has hypo, then think of three medical causes: renal impairment, hepatic impairment, gastrointestinal impairment. If you feel confident that these are not there, then think of three endocrine reasons for hypo: hypopituitary, hypothyroid, hypoadrenal. And in such cases, it may be a good idea to refer to a specialist. If there is an atypical response, lot of glycemic variability. Some days patient responds very well, other days glucose levels are high, sugars are all over the place. Again, no harm in getting a second opinion. So this is early on in the follow-up. But most of the referral in diabetes care will be late in the follow-up. That is when a patient develops acute or chronic complications, especially when these chronic complications are atypical or distressing to the patient. You have not seen such a presentation of a complication. The symptoms are causing distress. Patient is upset. In all situations where the patient is distressed, and let us say you have taken a week or 2 weeks or 4 weeks to treat, you are not able to manage, please send the patient for a second opinion and be very upfront with the patient. I am sending you for a second opinion because you are in distress. I cannot see you in so much pain. Why don't you go seek a second opinion and then come back to me? Then we'll live this journey of diabetes together. Also, if the complication is life threatening, limb threatening, or organ threatening, an immediate referral is warranted. Life threatening, like diabetic ketoacidosis or acute myocardial infarction. Limb threatening, like uh, limb threatening foot ulcer, which may be gangrenous, which may be moving towards gangrene. Today, I referred a patient, an elderly lady, my booked patient. Usually, she comes walking to the OPD. Today, they asked me, Sunday morning, they asked me to come outside and see her. She was not able to walk, and she was sitting in a three wheeler. Her her foot was not black, it was violet in color. Had it been 2 or 3 weeks ago, immediately I would have said, Madam, it's because of the cold. That's why it doesn't matter, go back. But today was a sunny morning. So it was a violet color. I sent her for a Doppler, and it turned out that right from the popliteal fossa onwards, there was no blood circulation at all. So this is impending gangrene, and we referred her immediately. So, but what was the cue to that limb threatening thing? She was not able to walk into the OPD. If she had walked into the OPD, it is possible that because it is winter and it is cold, I would not have asked her to remove her socks. And I might have made a mistake. Organ threatening examples would be maybe visual impairment, where the eye is threatened, uh, gallstone with severe pain abdomen. You are worried about rupture or emphysema, then again you will refer. An upper urinary tract infection which has not responded to antibiotics for 2 weeks, then don't take a risk. Please refer. So, this is how you will decide whether to refer or not. But anytime you feel that the quality or the quantity of life is being threatened, do take a second opinion. We've spoken of diagnosis, early follow up, and late follow up, the indications for referral. Let's talk about general follow up. Let's talk about every patient that you see. If everything is concordant, the patient's symptoms, signs, surrogate laboratory abnormalities, and the patient's response to therapy all are concordant with each other, then we continue treating. But if you find discordance between symptoms and signs, Let us say patient says, I have no complaint whatsoever, but the patient turns out to have a BP of 210 by 110. Something is wrong somewhere. If there is a discordance between clinical findings and biochemical findings, biochemistry says glucose is 36. Clinically, patient says I am hale and hearty. If there is a discordance between SMBG and HbA1c, patient gives you beautiful reports. Fasting 100, PP 140. Fasting 105, PP 160. But HbA1c is 9.9. There is discordance. If there is discordance between complications, patient has severe nephropathy, but there is no retinopathy. So there is a discordance between microvascular complications. Patient has severe cardiac autonomic neuropathy, but patient doesn't have albuminuria. There is discordance. Why is it there? There might be a separate reason. Again, it will be a good idea to refer. Referral, of course, will finally be decided by ourselves and our expertise. How much of expertise do I have in managing cardiac autonomic neuropathy? How much of expertise or interest do I have in managing genitourinary complaints like erectile dysfunction or premature ejaculation? Maybe I have the expertise, I have the interest, but do I have investigative and therapeutic modalities available? Do I have experts like surgeons, dietitians, gynecologists in my center? If yes, then I will refer to them. But if these expert facilities are available outside, then I would like to refer outside. Of course, I have to see about accessibility. If outside means 600 kilometers away, then maybe the patient is better off with me. If outside means 20,000 rupees for a consultation and my patient's total earning is only 5,000 rupees, then again, patient is better off with me. And finally, it boils down to patient acceptance. Is the patient willing to get referred or not? But whenever you are in doubt, whenever there is discordance, whenever there is discomfort, do suggest a second opinion, and patient will be grateful for that. When you are suggesting a second opinion, like in today's patient, they went happily to the cardiologist where I referred them. But 2 or 3 days ago, I had a patient. The patient came in psychosis. Again, I had to go outside to see this lady. And the chief complaint was we've been coming every day to Karnal from a nearby town, Taravadi. We've been coming every day. We've been showing the different psychiatrist every day. Patient is not responding to therapy. Abnormal behavior. She's not eating properly. Abnormal speech. She's not understanding us properly. The CT scan has been done, the MRI has been done. That is normal. I looked at the reports, the TSH was 100 plus. And then my clinical diagnosis was hyponatremia. So we got a sodium potassium done, and I think sodium came out to be 126 or 128. All this was done in about 40 minutes. I informed them that I do not have admission facilities and we need to refer you to the neighboring hospital. Because the TSH is more than 100, you are worried about fluid overload. So here the treatment is 3% normal saline. We phoned the neighboring hospital. They said, yes, they have 3% normal saline in their ICU. In Haryana, it is quite difficult to keep 3% normal saline in the chemist shops because this is also used in abortions. So you always have to explain why 3% normal saline is stocked with you. All this was done very nicely and very properly. Patient left us very happily and they said, yes, we'll go to the neighboring hospital and thank you for having diagnosed. But when they got there, I don't know what communication gap occurred, or the person whom we refer to handles cardiology practice. They were not able to understand psychiatry, hyponatremia, hypothyroid, linkage with cardiology. They picked up a fight. Most probably, that fight was actually um, due to the fact that they had to pay money to get admitted, and they left the hospital. And I really don't know what happened to the patient. But if I had referred, maybe much better. I had explained everything and also explained the desired outcome, the current status, saying that we do need to give this therapy. It is available only in select centers in our city and in our state. Then maybe the outcome would have been better. Patient would have got benefit out of the referral. You should also write a brief note or share investigations whenever you are referring to a specialist so that he doesn't repeat all of them again. And if you share your thought process, it is possible the the specialist will be able to treat in a faster manner. So these are some insights, some suggestions regarding when to refer, when not to refer. Let us look at our questions for last week. Last week we were talking about autonomic nervous system, and the first question was, diminished heart rate variability is the earliest indicator of cardiac autonomic neuropathy. That is true. Diminished heart rate variability. In general, there is a parasympathetic dysfunction that occurs first in CAN. First parasympathetic, after that sympathetic dysfunction. But this diminished HRV, heart rate variability, is detected within 1 to 2 years after diagnosis of diabetes. 1 year in type 1 in type 2 diabetes and 2 years in type 1 diabetes. So it can occur that early. One of the good treatments for this is yoga. And last time we used the word medical gym. So try to use mind gym, sorry. Try to use your mind as a gym and try to balance uh, the parasympathetic and sympathetic. Yoga is a good way of exercising and achieving good vagal tone. I am a student of Christian Medical College, Ludhiana, and I was very proud to see our ex principal, Dr. Alex Zachariah, in the news today. Dr. Zachariah was principal in 1987 when I joined MBBS, and he is credited with bringing something called primary care curriculum to India and to CMC Ludhiana. The way in which we learned during MBBS was totally different from what is done in routine colleges. Now, Dr. Alex Zachariah, after so many years of retirement, has come back to Punjab, his Karam Bhumi, his Dharam Bhumi. Actually, his Janam Bhumi is Kerala. He has come back and he has pioneered the concept of Kabaddi Yoga. He is using Kabaddi Yoga to treat drug addicts. What is the beauty of Kabaddi Yoga? I was thinking today. Now, in some sports, you have to be swift, like in a 100-meter race. In other sports, you have to be sustained, like in a marathon. For the swift sports, like 100-meter, you need adrenergic tone. For a marathon, you need vagal tone, parasympathetic tone. Kabaddi yoga is a beauty. It combines both. You have to be swift. You have to run into the opponent's side of the field. You have to raid and you have to come back. So you have to be fast. But your speech and your breathing, that has to be sustained. So when you say kabaddi, 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 okay, I got stuck. It was not very sustained on my part, but kabaddi, 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 the longer you sustain, the more the chances of success. So I think kabaddi yoga is a beautiful way of balancing parasympathetic and sympathetic. Let's all try it. And I would like to thank Dr. Zachariah for all that he has done for CMC Ludhiana, for the country, for my classmates, and for me. And today, Dr. Zachariah, after so many years of retirement, has given me more insight into cardiac autonomic neuropathy, cardiac autonomic function, and the treatment of cardiac autonomic neuropathy. The second question from last week was, which of the following is false? And the answer is B. Because in septic shock, hypotension will persist even after adequate fluid resuscitation. You will need to correct the sepsis as well. Let's come to this week's questions. So, our first question is, which of the following sentences is correct? A. Consultation with specialist will have no effect on achieving targets of diabetes control and CV risk. B. Consultation with specialists does improve performance of tests for diabetes management, such as foot examination, HbA1c measurement, lipid panel, urine microalbumin. C. It is all right for family physicians to refer every individual with diabetes who is at an advanced stage of the disease. And D. None of the above. Let us repeat the choices again. Only one of the following is correct. A. Consultation with specialists has no effect on target achievement. B. Consultation with specialists improves the performance of tests used in diabetes care. C. It is all right for family physicians to refer every individual with diabetes who is at an advanced stage of the disease. And D. None of the above. Our second question, our electrolyte NRZL 0 question. Which of the following sentences is false? So one of these is wrong. Which is wrong? First, to reduce heat illness, a body mass loss of more than 2% during exercise should be avoided. B. Female runners experience less negative net fluid balance relative to body mass as they have less stamina. C. Male runners exhibit higher sodium loss than male runners. And D. Individualized fluid and electrolyte replacement strategies should be recommended for runners in order to prevent heat stress and dehydration. Let us see again which of the following is false. Number one, we should avoid a body mass loss of more than 2% during exercise to reduce heat illness. Second, female runners experience less negative fluid balance as they have less stamina. Third, male runners exhibit higher sodium loss. And D, fourth, individualized fluid and electrolyte replacement strategies must be recommended for all runners to prevent heat stress and dehydration. With this, we've come to the end of today's talk. Uh, Allow me now to check all the questions. Lots of questions. And Dr. Anshul Singhai from Bhilai has pointed out a shortcoming in my talk. So let me come to that, Anshul. Well done. Okay. Dr. Anshul says Modi diagnosis is difficult. That is true. Uh, Even I'm not able to diagnose because we have to send for genetic workup. But if you have three generations of diabetes, the grandfather, the father, and the son, or the grandmother, the father, and the daughter, maybe, then chances of MODI are high. Usually, this will occur at about 20, 25, 30 years of age in young adults. They will be lean. You will not see too many stigmata of insulin resistance. You will also not see too many stigmata of autoimmune disease. And the hyperglycemia will be relatively mild, relatively mild. The response to low doses of sulfonylurea will be good. So that is how MODI will be treated. Even if you miss the diagnosis, it doesn't matter because overall the treatment will be the same as type 2 diabetes, only the dosage of drugs will be less. If you want confirmation, then many of the commercial labs are now doing genetic workup. The role of a psychiatrist or mental health professional in diabetology is important. But we should not refer everyone with diabetes to the psychiatrist. I refer very rarely. This is something where we all can upskill ourselves. So whether it is Dr. Anshul in Bhilai or Dr. Sunil Kota in Berhampur, then uh, we should be able to learn the basics of psychology, the basics of motivational interviewing. And if we are able to do that, if we are able to communicate properly with our patient, very rarely will we need to refer. When will you absolutely refer? If your patient has suicidal thoughts, suicidal speech, the patient just says, I'm thinking of committing suicide, then you should refer immediately. If patient has schizophrenia or severe substance abuse, again, good idea to refer. If there is discordance between biomedical issues and psychosocial issues, you are trying to control diabetes, you are not able to succeed. You did all the testing. You searched for all the infections, inflammations, invasions, all the iatrogenic issues. You couldn't find anything. It is possible there may be a psychological irritant. Take a history. Write a very light antidepressant or anti-anxiety drug. If patient doesn't respond, then we can always take the help of a psychiatrist. Dr. Vishnu Mulchandani points out that in impending gangrene, the limb will be cold, there will be no pulsations, and we should refer immediately because now very good quality interventions are available. They can do a stenting, they can do a bypass. The cardiothoracic vascular surgeon will be happy to do that. Supposing surgical facilities are not available, you can always refer to a a cardiologist who will start drugs like silostazole. We can start them ourselves. Silostazole 50 milligram twice a day, 30 minutes before meals. He will start dual antiplatelet therapy with high dose statins. We can do that ourselves. But he may wish to start heparin or anticoagulants. Uh, the novel anticoagulants like dabigatran, rivaroxaban, these are used more to prevent venous embolism or pulmonary embolism. For arterial gangrene, it is better to refer to a cardiologist. Dr. Jha has a query. Metformin affects kidney function, but not exactly. You can give metformin up till an eGFR of 30 ml per minute or more. Metformin directly is not renotoxic. But many times you will see that patients with renal disease, they come in taking so many drugs and they have gastritis, dyspepsia, loss of appetite. In such patients, I stop metformin for a few days and I tell them we are stopping the biggest tablet, the fattest tablet. They feel happy with that. And once their GIT comes back to normal, then we can start metformin again. But directly, it is not renotoxic. A very important question coming in from Chhattisgarh, that is how, whom and when to refer GDM. GDM, mostly you should be able to manage yourself. You should know when to screen for diabetes. So you must in India screen in the first trimester because that will rule out pre-existing diabetes. You must screen in the second trimester around 20 to 24 weeks because that will help pick up GDM. 90%, 85 to 90% of all GDM will be managed on MNT, medical nutrition therapy. So we must focus on MNT and we can handle that ourselves. The same amount of energy that you that you spend on deciding which drug to use, which trade name to use, we should spend the same energy on talking about MNT, medical nutrition therapy. A 3 plus 3 meal pattern. Don't limit calories too much. Allow the patient to eat each and everything. The things that you have to be fussy about are ghee, butter, and cream, and also sugar, jaggery, and other sweets. In case you have diabetes, you should know that
Hello. Yeah, I'm back. Sorry, there was a connection issue. I think we just lost our electricity here, outage. बिजली को भी ठंड लग गई. So we were talking about MNT. I'm sorry. If MNT is not sufficient, then we can always start drugs. We have two choices in pregnancy. One is insulin. The other one is metformin. Do note that metformin is approved by the DCGI for use in pregnancy. Now, if you have someone with a very mild kind of a GDM, the hyperglycemia is not severe, there are no complications, no maternal distress, no fetal distress. Ultrasound is normal, and there are just a few weeks left for term. You just have to manage for a few weeks. Then you may get away with metformin. If, however, pregnancy, GDM is diagnosed early on in pregnancy at about 20 weeks, 18 weeks, or glucose levels are high, you are not sure about fetal health or maternal health, then it is always safer to give insulin. Sometimes you will not be able to manage diabetes with insulin also because the insulin resistance is severe. Then we can add metformin. A few absolute contraindications. Any evidence of ketonuria, any evidence of fetal distress or fetal compromise. For example, uh, abdominal circumference very large, very low. Discordance between the head circumference and the abdominal circumference. In all such situations, insulin will be better. Now, coming to Dr. Anshul's question, that was when do we refer? Whenever you feel uncomfortable. If there is, if there is, if there is maternal compromise, if there is fetal compromise, or if there is discordance then we have an issue. It's a good idea to refer. We must be able to read the language of the ultrasonologist. That is also important. If you feel that there's an issue in the ultrasound reporting, then again, it is a good idea to refer. We've taken all the questions that I can see. I'm logged in from the phone now. Let me see if I can get the other questions. Okay, so we acknowledge the comments from Dr. Kishore Kulkarni and Dr. Shashi Khanna as well. And I think, Dr. Shashi, I think your answers are right, but even I've forgotten the ABCD now. Uh, we've taken all the questions.
So, unfortunately, both, because Dr. Kalra could take the session full, and he could also take all the questions. So we are here to only thank that we actually manage the timing very well, and that's what I was saying, sir. Actually, we could finish the session as well as we could finish the
Yeah.
question answer. So it's time for me to thank Dr. Sanjay Kalra that he has taken us the total session today and all the question answer as well. However, I would like to remind that early in the beginning of the session today, Rahul has reminded us that on 18th of February we are starting a new journey, which will be a parallel journey to this journey, which is diabetes essential. And now we are also starting diabetes and hydration. In this, there will be seven sessions will be there. Dr. Kalra will be hosting, and there will be every day a new panel member. Apart from that, we also want to tell doctors that we are going to have a season two, which we have been telling you, and we have not decided very soon, maybe because next week is the last session of Diabetes Essential with Dr. Sanjay Kalra. So we will be definitely giving you the date and the time every and at least agenda of next 6 months, so that we are through and we are very well informed that this is the day we will be continuing our journey with Dr. Sanjay Kalra. So with this, I thank Dr. Sanjay Kalra for staying with us and guiding us even today, because today's chapter was very clear that when to refer to a specialist. But looking into, I liked only one thing about it, that very clearly that even accessibility has increased in India, but because every maybe 50 kilometer, 100 kilometer, there will be a good endocrinologist or a cardiologist in India. But affordability, that's the biggest question which is still in my mind, because I fundamentally believe that India has got, even all the governments are giving the facility for Ayushman Bharat and for Manrega and all that. But ultimately, when people can go to or have a choice to go to a private practitioner, they will stick to the current situation. That's a long discussion ahead. I think I would request Dr. Saab to take this session also, maybe in the season two, that affordability in diabetes medicine, because that is a core of 10 crore population cannot be managed by, as you have also said, by specialists and all. So it has to be managed by primary care physicians. Affordability is a very important thing, because now there is a obviously affordability with so many government initiations. I don't doubt, but at the same time, we all know that how many are then getting cured at government hospitals, and how many are then getting in trade. So that's a very balanced thing. With this, I thank Dr. Sanjay Kalra, and good night and Jai Hind.
Jai Hind.